What do we mean by angina pectoris? Angina pectoris is basically chest pain of cardiac origin. Now it can be classical angina, which are generally in classical angina patient is asymptomatic at rest, but the chest pain occurs when the patient exercise or in any stressful condition and is relieved by rest again. Now then there is variant of Prinzmetal or vasospastic angina. It is caused by coronary vasospasm, generally seen more at night. And then unstable angina, there is a term called acute coronary syndrome, which include unstable angina, ST elevated myocardial infarction, non-ST elevated myocardial infarction. Now these are caused by atheromatous plaques in the coronary arteries and generally more commonly seen when there is any acute rupture of the atheromatous plaque in the coronary arteries followed by platelet aggregation. Now coming to the angina pectoris, chronically reduced blood supply due to deposition of the atheromatous plaque in the coronary arteries lead to the atrophy of the cardiac muscle and fibrous replacement occurs, leading to reduced myocardial contractility and congestive heart failure. Even conducting tissue may be damaged, leading to unstable cardiac rhythms. Now anti-anginal drugs generally relieve the cardiac ischemia by improving the cardiac artery pathology. And what are the drugs that can be used? Aspirin, ACE inhibitors and statins. They can modify the coronary artery disease and thus improve the prognosis in patients of myocardial infarction and unstable angina and ischemic heart disease. Now coming to the anti-anginal drugs available, these are nitrates. These can be short acting, long acting, like short acting glyceryl trinitrate, also known as GTN or nitroglycerin, long acting isosorbide dinitrate, isosorbide mononitrate, erythritol tetranitrate and pentaerythritol tetranitrate. Coming to beta blockers, they include propranolol, atenolol, metoprolol. And coming to calcium channel blockers, we can again divide them into three groups. One is phenylalkylamine, one drug is there verapamil, the other is benzothiazepines that include diltiazem, and the last is the dihydropyridines group of calcium channel blockers, which are more commonly used, and they include nifedipine, felodipine, amlodipine, nimodipine and others. Potassium channel opener like nicorandil, and the other anti-anginal drugs, they include dipyridamole, trimetazidine, ranolazine, ivabradine and others. So coming to the nitrates, as the name suggests, they have got nitrate radical. So all organic nitrates share the same action, they differ only in their course of time of action. They cause basically direct, non-specific smooth muscle relaxation, and thus they help in preload reduction because nitrates, they dilate veins more than the arteries. Due to the venous pooling of the blood in the human body, there is decrease in the preload on the heart, and thus they are improving the ventricular contractility. Coming to the afterload reduction, along with the venodilatation, some arteriolar dilatation is also seen that leads to basically slightly decrease in the total peripheral resistance, and thus they improve the anginal symptoms. With usual dose, if the patient does not stand still, tachycardia is not prominent. Actually, when the patient with use of organic nitrate, there is peripheral venous pooling of blood that leads to reflex tachycardia, and when the patient stands up, the patient may feel dizzy. So with usual dose, and if the patient does not stand still, tachycardia is not prominent, but with larger dose and if the BP falls significantly, there is reflex sympathetic stimulation leading to tachycardia, increased cardiac contractility leading to worsening of the anginal symptoms. All this can be prevented by lying down and raising the foot end. Redistribution of blood flow. In the arterial tree, nitrates predominantly relax the larger conducting coronary vessels than the resistance coronary vessels. This pattern of action may cause favorable redistribution of blood flow to the ischemic areas in the angina patients. Basically, these are the larger conducting coronary arteries and these are the resistance coronary vessels. Now, what happens in the ischemic zone? Basically, the blood supply via the resistance coronary vessels are compromised. Now, what happens as nitrates, they are dilating the larger coronary arteries. Basically, they are redistributing the blood flow more to the ischemic zone and thus they are improving the anginal symptom. In fact, nitrates do not appreciably increase the total coronary blood flow, but they preferentially increase the coronary blood flow to the ischemic zone. Now, mechanism of relief of angina. The relaxant effect on larger coronary artery is the principal action of nitrate, benefiting variant angina by counteracting coronary spasm. The main problem, the main pathophysiology in variant angina is the coronary vasospasm. By dilating the coronary vessels, they are counteracting the coronary spasm in the vasospastic angina. In the classical angina, undoubtedly, the primary effect is to reduce the cardiac work by decreasing the preload on the earth. By action on the peripheral vasculature, though increased blood supply to the ischemic area may contribute. That is the secondary action. Primary action, why the anginal symptom is relieved? Because of peripheral pooling of venous blood leading to decrease in the preload on the heart. Exercise tolerance of angina patient is improved because the same amount of exercise causes lesser augmentation of cardiac work. Heart and peripheral blood flow. Nitrates have no direct stimulant or depressant action on the heart. They dilate cutaneous vessels. So what happens with the use of organic nitrate? Due to dilatation of cutaneous vessels, there is flushing. So there is flushing in over the face and neck area. And again, due to dilatation of meningeal vessels, there is headache. There is headache with the use of organic nitrates. Splanchnic and renal blood flow decrease to compensate for vasodilatation in other areas. Nitrates tend to decongest lung. So they are useful in heart failure patient. Now, they have got, along with vascular smooth muscle relaxation, they have got relaxation effect on other visceral organs like bronchi, biliary tree and esophagus are mildly relaxed. Due to relaxation of esophageal sphincter, the GERD symptom may worsen. Effect on intestine, ureter and uterus is variable and insignificant. Mechanism of action, basically as the name suggests, nitrate, they have got nitrate radical which is rapidly denitrated to release nitric oxide. Now this nitric oxide, they stimulate basically guanylyl cyclase to increase the production of cGMP in the vasculature, smooth muscle, and thus they cause dephosphorylation of the cascade of enzymes including myosin light chain kinase, and because of dephosphorylation they reduce availability of the active form, that is phosphorylated myosin light chain kinase, and thus they are interfering with the activation of myosin and thus myocardial smooth muscle relaxation occurs. Raised intracellular cGMP, they also contribute to the increased intracellular calcium, may also reduce calcium entry, thus contributing to the relaxation. Pharmacokinetics, all organic nitrates are lipid soluble, so they are well absorbed orally, well absorbed from the buccal mucosa even, from the intestine and the skin. GTN and isosorbide dinitrate are both short acting and long acting, because short acting form is via the sublingual route where the first pass metabolism is basically not occurs, and longer acting form of GTN and isosorbide dinitrate is from the oral route. So the same drug having different basically duration of action because of change of route of administration. Adverse effect, as they are dilating the meningeal vessels, they are causing headache. So fullness is head, throbbing headache. Some degree of tolerance may occur with the chronic use of the drug. So when we use the drug continuously, the headache seems to disappear. Flushing, weakness, sweating, palpitation may be seen. Erect posture and alcohol accentuate these symptoms. Methemoglobinemia. This is a feature that is utilized in cyanide poisoning. We will come. Methemoglobinemia is not significant with clinically used drug. However, in severe anemia, it can be significant. Rashes are rare, though relatively more common with penta-erythritol tetranitrate. Tolerance, basically attenuation of hemodynamic effect and anti-ischemic effect is gradually fades away depending on the dose and duration of exposure. Now, this tolerance wins off rapidly within hours when the body is free of the drug. Clinically, no significant tolerance developed on intermittent use of sublingual GTN for attacks of angina. After anginal attack patient asle, we give sublingually glyceryl trinitrate to quickly improve the symptom. So, this intermittent use of glyceryl trinitrate will not cause tolerance, but when a patient is chronically given oral glyceryl trinitrate or isosorbide dinitrate, the patient may develop tolerance. So what we do basically, we give at least 8-hour drug-free interval so that tolerance does not develop. We give the drugs twice daily in the morning and the afternoon, and we keep the night time drug-free. So this tolerance builds up rapidly when the body is free of the drug. However, it may become important when GTN is used orally, transdermally, or by continuous intravenous infusion. Cross tolerance occurs among all nitrates. The most practical way to prevent nitrate tolerance is to provide nitrate-free intervals every day. Dependence on organic nitrate is now well recognized. Sudden withdrawal of the drug after chronic use can precipitate angina and MI. MI and sudden death have been reported. So withdrawal of nitrate should be gradual, like that of beta blockers. Beta blockers should also be withdrawn gradually in a patient on ischemic heart disease patient. The angina may precipitate. Interactions, as nitrates are potent vasodilators, so in combination with sildenafil, what happens? Severe hypotension, MI and death are on record. Additive hypotension is also possible when nitrate is given to a patient receiving other vasodilators. Now coming to glyceryl trinitrate, is a volatile liquid that is basically adsorbed on the tablet and rendered non-explosive and is given in a tightly closed glass container, not on plastic, so that it does not evaporate away. The sublingual route is used as and when basis to treat the classical angina patient, to treat the immediate chest pain due to angina, and for the maintenance, oral dosing or the transdermal patch can be used. Plasma T-half 2 minutes. When anginal pain is relieved, the remaining part of the tablet may be spit or swallowed. Problem the key, glyceryl trinitrate sublingually nile, there can be sudden hypotension. So when the patient is given sublingually glyceryl trinitrate, the patient starts to feel dizziness. So in that case, the remaining part of the tablet may be spit or swallowed, so that dizziness will decrease. A sublingual spray formulation has also been marketed. Sustained release oral capsule containing much larger amount of GTN can be used for the chronic prophylaxis. Cutaneous application as ointment was found to produce hemodynamic effect for 4 to 6 hours. Nowadays not used. A transdermal patch can be used for chronic prophylaxis, but the problem is development of tolerance and dependence. It is advised that the patch to be taken off for 8 hours daily. A transmucosal dosage form which has to be stuck to the gums under the upper lip has also been produced. Intravenous glycerol trinitrate is used to quickly relieve the patient with chest pain due to myocardial infarction. It provides rapid, steady, titrable plasma concentration for as long as desired. Now, it has been used for unstable angina, coronary vasospasm, left ventricular failure, accompanying MI, hypertension during cardiac surgery. What is the advantage? It limits the size of infarct in evolving myocardial infarction. Coming to isosorbide dinitrate, property similar to that of GTN. It is in the solid form, property similar to GTN, sublingually at the time of acute attack and orally for the chronic prophylaxis like that of GTN. Last dose should not be taken later than 6 p.m. Isosorbide mononitrate is the long-acting organic nitrate. It is an active metabolite of isosorbide dinitrate. Little first-pass metabolism, so inter-individual variation is not seen. Large dose to be taken in the afternoon. Erythritol tetranitrate and others, these are longer-acting nitrates used for chronic prophylaxis. Now coming to use of nitrates, this can be used in classical angina patient. It can be used in acute coronary syndrome and myocardial infarction. It can be used in congestive heart failure and left ventricular failure, biliary colic as it causes relaxation of the biliary muscles, biliary tissue, esophageal spasm, cyanide poisoning. Angina pectoris, it can be used in classical as well as variant angina. The sublingual GTN tablet or spray or isosorbide dinitrate can be used as and when required basis. Longer acting formulations of GTN or other nitrates are used on a regular basis for chronic prophylaxis, but keeping drug free interval daily. Development of tolerance and dependence may limit the usefulness, so 6 to 8 drug free hours daily are advisable. Acute coronary syndrome, it encompasses unstable angina, non-ST elevated MI and STEMI. Nitrates are useful by decreasing preload as well as by increasing coronary flow. The role of nitrates appears to be limited to relief of pain because no mortality benefit has been demonstrated in large randomized clinical trials. Although organic nitrates, they are relieving the symptoms in patients of classical angina, in patients of acute coronary syndrome, but in the long run they did not show any mortality benefit. Mortality benefit has been shown in patients of acute coronary syndrome and classical angina with beta blockers, with antiplatelet, with statin therapy and ACE inhibitor or ARB. These are the 4 drugs that are used to improve mortality. Myocardial infarction administered by carefully titrating IV infusion to avoid hypotension and tachycardia. GTN is frequently used during evolving MI in the intravenous route. Now, prognostic benefits appear marginal. Proper selection of patient is essential to give GTN, intravenous GTN. Kake debo amra when the systolic blood pressure is more than 90 or heart rate is lying in between the 50 or 100. We should not give the GTN infusion in right ventricular myocardial infarction because there is a chance of hypotension. Hypotension caused by nitrate limits the administration of beta blockers which have more powerful salutary effects, and patients who have taken sildenafil within 24 hours should not be given GTN. Nitrates afford relief by venous pooling of blood. Intravenous GTN is the preparation of choice in myocardial infarction. Now, cyanide poisoning, what happens? Nitrates generate methemoglobin, we know. Now, this methemoglobin rapidly dissociate again and combine with cyanide. So, basically what happens when we are giving nitrate in a patient of cyanide poisoning, nitrate is combining with hemoglobin to form methemoglobin. then that combines with the cyanide radical to form cyanomethemoglobin. Now this complex is readily dissociable and it again convert into the cyanide radical and methemoglobin. So what we do, we combine nitrates, with sodium thiosulfate. Now what happens, this sodium thiosulfate, hello, what happens, the sodium thiosulfate, they combine with cyanomethemoglobin to form basically sodium thiocyanate, which it does not readily dissociate, and and hence the person get freed of cyanide poisoning. Early treatment is critical. So the hemoglobin, what we are giving, sodium nitrite, 10 ml of 3% solution, it convert to methemoglobin, then cyanide combines with it to form cyanohemoglobin, then we are giving sodium thiosulfate. What happens, there is methemoglobin freed and sodium thiocyanate is formed, that is easily excreted in urine. In biliary colic, due to disease or morphine, sublingual GTN or isosorbide dinitrate can be used. In the esophageal spasm, sublingual GTN can help relieve the symptoms. Coming to beta blockers, they do not have any effect on the coronaries, but they, however, they flow to the ischemic subendocardial region is not reduced. How they work? They decrease the cardiac work by, and thus they increase the basically they improve the oxygen consumption. So beta blockers act by reducing cardiac work and O2 consumption as a consequence of decrease in the heart rate and inotropic state and mean blood pressure. This effect is marginal at rest, but when the person in stressful condition or when does the exercise, beta blockers limit increase in cardiac work there by its anti-adrenergic action. Cardioselective drugs, cardioselective beta blockers like metoprolol, atenolol are preferred over the non-selective beta blockers. The dose has to be individualized. The drug has to be given on a regular schedule. Abrupt discontinuation of the drug should not be there, as it may precipitate severe attacks, even MI. Beta blockers are routinely used in unstable angina or NSTEMI or STEMI. However, given only after starting the nitrate plus minus calcium channel blockers in patient of vasospastic angina. Now coming to calcium channel blockers, is the second group of drug. As we know, verapamil, nifedipine, diltiazem are there. The dihydropyridine group of calcium channel blockers are the most commonly used drug clinically. These are most potent calcium channel blockers. Now pharmacological action, basically they inhibit calcium mediated slow calcium channels of the action potential in the smooth and cardiac muscle cell, and thus they are causing vascular smooth muscle relaxation. So the two most important actions are smooth muscle relaxation, especially in the vascular tissue, and again they have got negative chronotropic, inotropic and dromotropic action of the heart, particularly more with verapamil. So smooth muscles, basically the calcium channel blockers, they cause relaxation by decreasing the intracellular availability of calcium. They markedly relax arterioles but have milder effects on the veins. The dihydropyridine group of calcium channel blockers, they have got more pronounced effect on the vascular smooth muscle compared to other calcium channel blockers. Now, they have got negative inotropic action by acting on the working atrial and ventricular fibers, where they are decreasing the availability of calcium. Also, verapamil slows the sinus rate and AV conduction. How? Because the SA node and the AV node, the phase 0 is maintained by the calcium channel, not by the sodium channel. Again, the phase 4 repolarization is maintained by the calcium channel. So what happens? By acting on that phase, they are slowing the recovery of the SA node and AV node, and so verapamil is slowing the heart rate and AV conduction. The action is more pronounced with verapamil and diltiazem. Effect of diltiazem on sinus node automaticity and AV conduction is similar to that of verapamil. On the heart, basically heart rate is decreased by both verapamil and diltiazem, but increased by nifedipine and other dihydropyridine calcium channel blockers because of reflex tachycardia. They have got more pronounced vasodilator action, so there is reflex tachycardia. Verapamil, it dilates arterioles and has some alpha adrenergic blocking action. The heart rate generally decreases, AV conduction is slowed down, but cardiac output is maintained. However, ventricular contractility may be markedly impaired in congestive heart failure patient. The side effects are nausea, constipation, important one, bradycardia may be there. It is contraindicated in patients of second degree and third degree heart block patients. Why? Because of sinus node depression. It may precipitate congestive heart failure in the patients with pre-existing disease. Cardiac arrest may be seen on rapid intravenous injection. Verapamil should not be combined with beta blockers. Why? Because beta blocker is decreasing the heart rate, verapamil is decreasing the heart rate. So there may be additive sinus depression, conduction defects, or asystole may occur. Again it may increase the level of digoxin in the blood by decreasing its clearance. It should not be used along with other cardiac depressant like quinidine, like disopyramide. Diltiazem, like verapamil, diltiazem has got lower effect on the vasculature, but they have got more pronounced effect on the SA node, on the AV node, and the effect on contractility is intermediate between the verapamil and the dihydropyridine group of drug. So, fall in BP with little change or decrease in heart rate, they dilate coronaries. Side effect profile similar to that of verapamil. They can increase the plasma digoxin level. They should not be combined to patients with pre-existing sinus or AV nodal disease. Only low dose should be given to patients on beta blockers. Nifedipine is a prototype dihydropyridine group of calcium channel blockers with rapid onset and short duration of action. Now, as described above, it does not depress SA node. As described above, it does not depress SA node or AV node, which is done by verapamil and diltiazem. They cause reflex sympathetic stimulation, causing tachycardia, increased contractility and cardiac output. Coronary flow is increased. Now, frequent side effects can be seen like palpitation, flushing due to cutaneous vasodilatation. This can be reduced by starting with lower dose or fractionation of the dose or using of retard formulations. Ankle edema is common with the use of dihydropyridine calcium channel blockers, but it does not occur due to fluid retention. This occurs because of the preferential dilatation of the pre-capillary vessels than the post-capillary vessels. Pre-capillary vessels গুলো বেশি dilate করছে, তার জন্য hydrostatic pressure in the capillaries is increased. That leads to the pedal edema. Now, they increase urine voiding difficulty in elderly males. Gastroesophageal reflux may be worsened. It has also been reported to hamper diabetes control by decreasing the insulin release. Other dihydropyridine calcium channel blockers, they have got pharmacodynamic profile similar to that of nifedipine. The main difference in the pharmacokinetic properties. The slower and longer acting ones induce lesser sympathetic stimulations. They are the favored dihydropyridine calcium channel blockers. They increase mortality among post-MI patient because of the use of regular short-acting nifedipine formulation. Amlodipine. Amlodipine is one of the longest acting dihydropyridine calcium channel blockers. Is most commonly used preparation. Now the early vasodilator effect can be largely avoided because of the long acting formulation. Oral bioavailability is higher and more consistent because of lesser first pass metabolism. Volume of diurnal fluctuation in blood level is small and the action extends over the next morning. The T half is around 40 hours. So duration of action is more than 24 hours. Amlodipine effective at half the dose and is claimed to cause less pulmonary edema. Pharmacokinetics, most distinct dihydropyridine calcium channel blockers, most popular. The vasodilator effects can be largely avoided by use of it. Oral bioavailability is higher and more consistent. These are the other dihydropyridine calcium channel blockers that include felodipine, nitrodipine, lacidipine, nimodipine. Nimodipine has got selective action on the cerebral vasculature. So they find use in subarachnoid hemorrhage or ruptured congenital intracranial aneurysm. Now, pharmacokinetics, 90 to 100% absorbed orally. They have got marked inter and intra-individual variation because of high first pass metabolism. They are highly plasma protein bound. They have got extensive tissue distribution. On chronic use, verapamil decreases its own metabolism. Now uses, calcium channel blockers can be used in angina pectoris, in hypertension, cardiac arrhythmias, hypertrophic cardiomyopathy. Now coming to angina pectoris, they are effective in relieving the frequency and severity of classical as well as variant angina. Now they are more useful in variant angina because they are basically causing relaxation of the coronary vessels. They work in classical angina by reduction in the cardiac work. Myocardial ischemia, however, may be aggravated by short-acting DHPs like nifedipine. Now, verapamil and diltiazem, they reduce reinfarction and mortality in myocardial infarction patients, similar to that achieved by the beta blockers. So, in person of angina pectoris or acute coronary syndrome, where beta blocker is contraindicated, non-dihydropyridine calcium channel blockers like verapamil can be used. Now, capacity of calcium channel blockers to prevent arterial spasm find its use in the variant angina. No significant difference in efficacy in the variant angina among different calcium channel blocker preparations. Calcium channel blocker, however, is not a first line treatment for unstable angina. So, what are the first line treatment for unstable angina? These are beta blockers, antiplatelets, statin, nitrates. Now, other use, they can be used in hypertension, in cardiac arrhythmias. Verapamil and diltiazem are used in supraventricular arrhythmias to control the ventricular rate. Hypertrophic cardiomyopathy, due to the negative inotropic effect, verapamil has got used in the hypertrophic cardiomyopathy. Also, nifedipine, they are used in premature labor because they relax the uterus, and then verapamil find its use in nocturnal leg cramps, while diltiazem can be used in Raynaud's disease. Drug combinations, generally sublingual GTN is used as and when basis. Generally, we start with a monotherapy as a prophylaxis in a patient of angina patients. Now, when monotherapy is unable to provide adequate relief in the maximum tolerated dose, then we can add 2 and then 3 drugs. Now, beta blocker can be combined with the long-acting nitrate preparation. What is the advantage? Beta blocker causes bradycardia, nitrate is causing tachycardia. So, tachycardia due to nitrate is blocked by beta blocker. Next is tendency of beta blocker to cause ventricular dilatation can be counteracted by nitrate, and lastly, beta blocker reduce the total coronary flow, which is counteracted by the nitrate. Again, beta blocker can be combined with slow acting dihydropyridine calcium channel blockers, not with verapamil, not with diltiazem, because of sinus node depression. Nitrate can be combined with the calcium channel blockers, especially in vasospastic angina. In the more severe and resistant cases of classical angina, use of all the three classes is indicated. Now coming to potassium channel openers, the minoxidil and diazoxide were the initially used potassium channel openers, but their use has declined nowadays. Novel potassium channel openers like nicorandil, which is more commonly used, pinacidil and chromacalin have been developed in 1990s. Now coming to the nicorandil, they have got dual mechanism of action. Number one, they basically activate the ATP sensitive potassium channels, and thus they are causing vasodilation. Again, they are also releasing nitric oxide like that of organic nitrates. They are acting as a nitric oxide donor and they are relaxing the blood vessels. However, no significant cardiac effect on the conduction, on the contractility is there. Now, like that of basically nitrates, nicorandil should not be combined with sildenafil because of the risk of severe hypotension. They are the alternative anti-anginal drugs. They are not used commonly. When the use of the first line drug is ineffective or contraindicated, then nicorandil can be used as an add-on drug in the resistant angina when combined with other drugs. Now other anti-anginal drugs, dipyridamole is a powerful coronary dilator. They prevent uptake and degradation of the adenosine number 1 and they fail to relieve anginal symptoms or avert ECG changes. They show coronary still phenomenon. What is coronary still phenomenon? As they are a potent vasodilator, they increase the coronary blood flow irrespective of the large conducting coronary vessel or the resistance vessels. So what happens? More blood is diverted to the non-ischemic zone. So patient, instead of getting relieved with the pain increases in angina. Now dipyridamole inhibit platelet aggregation also. They are used for prophylaxis of the cerebral and coronary thrombosis in post-MI patient and post-stroke patient. Trimetazidine, they act in angina patient by non-hemodynamic mechanism. How? They basically inhibit the fatty acid metabolism in the myocardium. What happens? In the ischemic myocardium, the glucose metabolism is decreased. They increase the fatty acid metabolism. Now this trimetazidine, they are inhibiting the fatty acid metabolism there and glucose metabolism is increased. Thus they are salvaging the ischemic myocardium. So they are also called PFOX inhibitor or fatty acid oxygenation inhibitor. They are generally well tolerated. They are also used or advocated for visual disturbance, tinnitus, Meniere's disease. They are generally used as an add-on therapy in patients of angina and post-MI patients, like that of the other like that of dipyridamole. Coming to ranolazine, the primary action is they are inhibiting late sodium current in the myocardium. They are also inhibiting the fatty acid metabolism like that of the trimetazidine, but that's their secondary action. They have got no effect on heart rate or on BP. They are metabolized by CYP3A4, so they should not be used in patients taking CYP3A4 inhibitors. Ivabradine basically is a pure heart rate lowering drug. They have got no action on the blood pressure. So what does they cause? They cause blockade of the cardiac pacemaker cell F channels in the SA node, and thus they are decreasing the heart rate. The heart rate reduction occur without any other electrophysiological or any effect on the inotropy or the lucitropy of the heart. They are used in chronic stable angina in patient with sinus rhythm in whom beta blocker is contraindicated, not tolerated, or even in spite of use of maximum tolerated beta blocker, the heart rate is not controlled to the desired value. In those cases, ivabradine can be used. And they are also used in inappropriate sinus tachycardia, but they have got no role in any arrhythmias. Now, drug therapy in myocardial infarction. So, basically myocardial acute coronary syndrome, they are including unstable angina, NSTEMI and STEMI. By myocardial infarction, we mean STEMI and NSTEMI. Now, why the myocardial infarction occurs? Because of ischemic necrosis of a portion of myocardium due to the sudden occlusion of a branch of coronary tree. Now, drug therapy, definitely hospitalization should be there. Number one, oxygenation. Oxygenation is advocated in patients of myocardial infarction only with hypoxia when the peripheral oxygen saturation is less than 90. Number two, relief of pain, anxiety and apprehension. There the nitrates and opiates can be used. Nitrates are the drug of choice for relieving of the pain. When the pain is not relieved by nitrate alone, then opiates can be used. What the treatment of choice here to relieve the pain? Rapid coronary revascularization is the treatment of choice when the pain is not used with nitrates. Prevention of thrombus extension, embolism and venous thrombosis. Aspirin should be used in the loading dose 165 to 325 milligram to be chewed in non-enteric coated formulation, and then the daily oral maintenance dose is given in a dose of 75 to 150 milligram per day. Along with aspirin, oral P2Y12 inhibitor also is used in loading dose followed by daily maintenance dose. It includes clopidogrel, prasugrel, ticagrelor. Parenteral anticoagulation, that includes unfractionated heparin, low molecular weight heparin, fondaparinux can be used in all patients of MI to treat the underlying pathophysiological process. Prevention and treatment of arrhythmias. Prophylactic IV beta blockers can be used in selected patients of MI to reduce the infarct size. Tachyarrhythmias can be treated with intravenous lidocaine, with procainamide or amiodarone. Bradycardia and heart block can be managed with atropine or electrical pacing. Pump failure, patient with MI can present with heart failure, that is pump failure. In those cases, furosemide can be used if pulmonary capillary wedge pressure is more than 20. Vasodilators that include GTN can be used, that which can be venous or combined dilator. Definitely GTN is preferred. Nitroprusside can be used. Inotropic agents, dopamine or dobutamine in case of hypotension. Rarely digoxin can be used if atrial fibrillation is present. Lipid management, high dose statin therapy is the drug of choice in patients of myocardial infarction. In patients who are not tolerating statin therapy or the maximum tolerated dose has been used, but the desired cholesterol level is not reached, LDL cholesterol not reached, in those cases non-statin therapies can be used combined, like ezetimibe, PCSK9 inhibitors like bempedoic acid. Then thrombolysis and reperfusion, fibrinolytic agents like streptokinase, urokinase, altiplase, tenecteplase can be used to achieve reperfusion of the infarcted area. And definitely the treatment of choice is primary percutaneous coronary intervention. একটা পেশেন্ট যদি মায়োকার্ডিয়াল ইনফার্কশন নিয়ে আসে, কোন হসপিটালে এসছে, whether it is PCI capable, primary percutaneous angiography যদি করা যায়, then is the treatment of choice. If it is not possible, the hospital has not got the facility. In that case, if the hospital can transfer the patient within 2 hours to start the PCI, then that is preferred. If that is not possible, then definitely fibrinolytic agents can be used. Among the fibrinolytic agents, there are 2 varieties. One is fibrin non-specific, that include streptokinase, and one is fibrin specific, that include altiplase, tenecteplase, reteplase. Now, fibrin specific fibrinolytic agents are preferred because of lesser chance of bleeding and because of more efficacy. So, primary percutaneous coronary intervention with stenting is now the preferred revascularization process wherever applicable. Now, prevention of remodeling and subsequent congestive heart failure. Here ACE inhibitors or angiotensin receptor blockers are of proven efficacy and they give long-term mortality benefit. Prevention of future attack, for that we use antiplatelets, aspirin or clopidogrel. We use beta blockers in the maximum tolerated dose to reduce risk of reinfarction, congestive heart failure and mortality. And for control of hyperlipidemia, we prescribe dietary modifications and definitely hypolipidemic drugs. Statin is preferred, where statin is contraindicated, non-statin therapy can be given.